All right. Well, good afternoon, and welcome to our November information session. Today, we're going to be talking about U.S. core data for interoperability, so USCDI and USCDI plus quality. So we're going to be talking about what they are and what's ahead. My name is Haley Von Holst, and I am the information session lead for the CMS Measures Management System contract supported by Battelle. So we're joined here today by two presenters. Very excited to have them from the Office of the National Coordinator for Health Information Technology, Al Taylor and Lisa Wagner. So again, we're so excited to have them here to dig in this topic. They are our experts. If you would like to download today's slides, they're available on the MMS Hub. We'll share a link at the end of the presentation in the chat there. We will also post a recording of today's session on the MMS Hub in a few weeks. And so you should have access to that as well. Okay, so a few more things, then we'll jump in. But as part of the Measures Management System's outreach task, CMS produces these information sessions throughout the year to educate about quality measurement topics and engage those interested in measure development and maintenance. So in short, we host these sessions for you all. So we highly encourage you to submit questions throughout today's presentation using the Q&A feature near the bottom of your screen. And we'll try to address as many of these questions as we can at the end of the presentation. So thank you again, everyone, for being here. And I'm going to turn it over to Al to get us started.
Great. Thank you, Haley. Next slide, please. Again, my name is Al Taylor. I'm a medical informatics officer in the Office of Technology at ONC. I am originally, by training, I am an OBGYN. I was in the Army for 24 years and came to ONC about 8 or 9 years ago. And I've been working in standards. And in particular, I've been the technical lead for USCDI for the last, coming up on 5 years now, as we get into our 5th year of USCDI. Next slide. The ONC, for those who don't know, was originally founded in 2004 by executive order. It was a very small office in the immediate office of HHS, but the fund really got started in 2009 when it was our authorities were outlined in the high-tech health IT and economic and clinical health law, and that defined the meaningful use program, and it identified certain things that electronic health records, which are incentivized it set ONC as the authority in establishing those criteria for what meaningful electronic health information is supposed to accomplish. We have done that, and we've executed our certification program now for the last 10 plus, almost 12 years now, certifying or authorizing the certification of health IT for a variety of different purposes, not the least of which was CMS, the use of electronic health information in CMS reporting programs and CMS billing programs as well. And our overall goal is to achieve interoperability of health IT. That is, we got further, we were granted further authority in the 21st Century Cures Act. The Cures Act was written in 2016. A lot of our authorities were rewritten when our Cures Act edition final rule came out in 2020. It includes covering things like information blocking, identification of additional standards, this concept of the Trusted Exchange Framework and Common Agreement, or TEFCA, and also some authority to work to align health IT policies and standards across all of HHS. Next slide, please. So USCDI, United States Core Data for Interoperability, what is it? Next slide. It's several things. One is a core set of data needed for patient care, and it's a core set needed to inform patient access to their health data. In addition to identifying this set of data that's required, needed, and desired for a variety of different purposes, it's also come to serve as a baseline for other uses. So when other HHS agencies, actually other federal agencies, have a particular need for health data that is of health data for whatever that purpose is, be it CMS reporting, Social Security disability ratings, or anything else that might be used, USCDI stands as a baseline. So some reporting programs, some federal agencies may require additional data above and beyond what USCDI is, but we can always refer to USCDI as the base. And if we need extra stuff, we can those programs can identify those rather than going into every little detail about every part of what's part of USCDI. So it's that baseline, even though it's a moving baseline, it's a baseline that can be used by others to reference. We've also identified, when we established USCDI, we created a predictable, transparent, collaborative process, and we try to hold true to each one of those components of this process. It is public. The expansion is based directly on public input, and that public input can come from agencies, man on the street, person on the street, or other organizations within healthcare and elsewhere. Next slide. This outlines some of the same things. The key point to take away from this is that USCDI identifies the data set. Other parts of the ONC certification program defines how that data set is used. Interoperability is a key part of USCDI. It's the actual I in USCDI. And the interoperability means that data has to be able to be exchanged, accessible, readable, understandable, and exchangeable. And that exchange happens through a couple of different mechanisms that are defined by our certification program. One of them is the Consolidated Clinical Data Architecture, which has a number of different templates or document types that can be used to exchange data in different formats. The content of those CCDA documents include USCDI data. Similarly, a newer mechanism of transfer of exchange of information is through FHIR, Fast Healthcare Information Resources. This is a machine readable exchange format, and the content of the information that's exchanged using the FHIR, in this case, the US core build of FHIR, the information that is contained within those exchanges in those FHIR resources are defined by USCDI. There are other things in FHIR resources, but USCDI sits at the core of that information that is exchanged using those mechanisms. USCDI, this was the definition of USCDI version 1. As most of you know, ONC published their new certification and other health IT rule called HTI 1. It is currently in notice of proposed rulemaking process, or it's in rulemaking. It's not finalized yet. There are some specific stipulations that change how USCDI is used and required, and we hope to publish that soon. And should those changes be implemented, those will override past requirements under USCDI version 1. But USCDI version 3, which we'll talk about in a minute, is the new standard, would be the new standard when this rule is published. Should this rule be published as is. Next slide. This shows the progression using this transparent, predictable, collaborative process. USCDI version 1 started as an expansion of the common clinical data set, which previously was used to exchange information using ONC certification criteria. USCDI version 2 added a couple of different elements. Next slide, please. added some additional data elements. In particular, expanded the availability of STOH data and several key demographic components, including sexual orientation and gender identity. We also made other expansions in other areas as well, adding several data classes that did not have a footprint in the Common Clinical Data Set or USCDI version 1. Next slide. USCDI version 3 added additional data elements and classes that focused on the administration's priorities around promoting equity, reducing disparities, and supporting public health data interoperability. And as I mentioned, version 3, with a few modifications to version 3, is proposed to be the new baseline standard. The effective date, apologize for that. That effective date is not going to be the reporting date that was tentative as of the initial publication of the proposed rule. We don't have an exact final date, but it should be sometime down the road, perhaps a year or more after this date. Next slide. And then finally, USCDI version 4, which we published in July, adds additional data elements in a newly expanded health status assessment data class, including and some additional information that is useful during medication reconciliation process and the development of advanced care planning documents. Next slide. As far as the USCDI process goes, I want to dive a little bit into this because many of you on the call have participated very actively in this process, and we're aware of that, and we want to just highlight what we are doing and what we intend to continue to do. Next slide. I just want to touch on this for a minute. USCDI is in a cycle, and at any given time, we might be working on different aspects of different versions of USCDI. USCDI version 3 was just made available for updating this summer. As we were working on version 4, which we had a submission and comment process that ended. We finished the submission and comment process on USCDI version 4 and published the final in July. But at the same time, we were collecting information on what ought to go into USCDI version 5. That includes submissions through our new data element request system and comments on data elements that were submitted for addition in the past, but not added to a previous version of USCDI. And so we reviewed those comments and we reviewed those submissions, and we are now in the upper left corner of this cycle, or this quadrant of the circle, working on what is going to go into draft V5. Once we publish draft V5 in January, we are going to go through a approximately 3-year that's a long time, a 3-month public comment and review cycle, including getting input from our HITAC committee, our advisory committee. We will digest all of those comments and feedback and then develop what ends up going into the final. It could be more data elements, it could be different data elements, it could be less data elements, but we will this will all be based on the input that we got during the January to April timeframe. And then again, we hope to publish USCDI version 5 in and around July of next year. Next slide. We get a lot of submissions and comments on previously submitted data elements about what should go into the next version or another version of USCDI. We have to evaluate the maturity and readiness of every single data element that is submitted. Some are ready to go. They could potentially be adopted if they were in policy. Other ones need additional standards development work. They need additional testing. And those are ones that are not immediately considered for addition to USCDI, but with additional work, piloting, testing, implementation guide development, they could be considered for future versions of USCDI. Once we through that whole filter of kind of leveling these out for maturity and readiness, we still have many more data elements than we can add to any new version. We're limited in the ability to add a number of data elements in USCDI, and we have this concept called aggregate lift that's at the end of this list, and that means that we could have a lot of great ideas, a lot of very mature data elements, but we are not in a position to put the burden on standards developers, health IT developers, and actually providers and implementing systems that have to digest that and then put that into practice. And so, in addition to considering new data that addresses healthcare disparities, underserved communities, behavioral health, and public health, we have to also consider some of these technical criteria that are listed in the second half of this list as to how we come up with that final list of additions. In the past, we have added on the order of about 20 new data elements in each of the last four update versions of USCDI, and that pattern will likely continue somewhere in the ballpark of that number, not an exact number, but we have to be considerate of those who are going to take that and put it into practice. Next slide. This is just a real quick overview of the new data elements that we added in USCDI. I mentioned the ones that we did add. We had a significant expansion in laboratory data elements, which helps the public health reporting systems gain access to and help mobilize those data. New data elements in the facilities, medication data class, and then several new health status assessments. So that's just, I'm not going to go through each one of these, but these are the new ones that were added. The little symbols indicate those relate to the prioritization criteria that we mentioned in the previous slide. Next slide. And this is just a summary of all of the data elements that comprise USCDI version 4. Next slide. I'm going to turn it over to Lisa Wagner, who's going to talk a little bit about kind of what happens. What happens. We have USCDI as baseline, and then where do we go from here? Take it away, Lisa.
Great, thank you, Al. My name is Lisa Wagner. I'm a senior policy advisor in ONC. I've been working on USCDI Plus for the past year or so, though, as you all heard from Al just recently, we learned over the past several years working in USCDI, there was a clear call and need for more program or domain-specific data element lists. And so ONC realizing this, hearing from partners, and realizing that USCDI is really only expanding incrementally over time with really core data elements, that we did find this need for more domain-specific data elements that could be an extension to what is the current USCDI. And so we've been working over the past couple of years to develop a collaborative process for partners to sort of coalesce around specific programs, requirements, and data element requirements for programs. And ONC officially launched USCDI Plus in fall 2021, though that's really like when it was first announced, and we've really been spending the past couple of years trying to figure everything out. Next slide, please. Sorry. So we just as USCDI expands incrementally over time by a transparent, established, and collaborative process, and weighing both kind of benefits and impacts on industry, USCDI Plus is intended to mirror a similar process and establish data element lists to harmonize and align data needs for partners. When we set out on USCDI Plus, our initial domains were quality and public health. And over time, we've continued to expand and our focus to also include cancer, maternal health, and behavioral health program needs. And really, our initial start is really around just the sheer need for alignment across these different program areas. And we'll continue to work on this alignment over time. Next slide, please. And as I mentioned, USCDI Plus is meant to be an iterative process where we're making changes and updates on a rolling basis similar to USCDI. So this work will allow partners within and outside government who are working in the same program areas to be able to reference the same data standards or data elements as well. Next slide, please. So the overarching principles of USCDI Plus are really around harmonization. So the idea being that we're starting with USCDI as our base and first doing an analysis there to see of these particular program areas we're focused on, whether that's quality, cancer, public health, what really overlaps with the existing USCDI data element list. And we're also trying to, across domains, align those same data elements as well, working to think through as we're adding in more additional data elements for quality, does that also apply for something like cancer or public health as well, to really try to harmonize as we're going along. All along trying to align these different naming conventions. And really there's this balance between granularity and clarity in the sense that USCDI and USCDI Plus aren't necessarily the details down to a particular implementation guide. They are intended to be higher priority concepts. And our hope is that over time we can still reference specific fire standards as a part of the particular data elements that we've identified, but also build a community around gaps in specific data standards where we can say within a quality program or within cancer, that if there are data standards that are missing, that we're identifying that across different program areas and working together in this collaborative process. Next slide. The data element list developed under USCDI Plus will include multiple data concepts with underlying data elements and standards to meet program needs across HHS and allow outside entities such as technology and measure developers to harmonize in their future work. Really, the idea to reduce the burden of data collection, reporting, and analysis. And as you can see in this visual, we are looking to identify new data elements that are not included in USCDI, but remain important for program-specific areas that want to ensure data element and standards harmonization. Next slide, please. So now we'll turn it to just looking at USCDI Plus quality and how that can be applied or implemented. Next slide, please. So for USCDI Plus quality, ONC, we started working with both CMS and HRSA to identify USCDI Plus quality data elements. And in particular, our collaboration with CMS was around addressing core data and interoperability needs for CMS's fire quality reporting initiatives. And that and health IT certification, which includes developing a future fire regulatory framework and certification model, recommendations on use of fire implementation guides, and advising and supporting future policy making and implementation of testing tools and resources. And while quality measurement within CMS programs is a key starting point, it is just one broader part of the broader USCDI Plus quality domain. We've also started engaging with a wider range of public and private partners, including AHIP and NCQA and NQF, all with this within the quality measurement space to support quality reporting, measurement, and improvement. This initiative is identifying opportunities for policy alignment around quality reporting programs under existing authorities at HHS agencies. And we're looking to support collection and harmonization of quality measured data elements for the broader quality community, including specialty registries, payers, quality improvement organizations, and quality improvement models. And as we continue to develop this data element list with clear clinical concepts mapped to data elements and standards, we're going to publish a final data element list for the quality community to support their work and align their approach to interoperability goals. Next slide, please. So the initial USCDI Plus quality data element list builds on analysis and review of existing quality data elements and the exploration of existing implementation guides. We're also looking at what's in the work with changes or updates to quality specific data elements. And this is feeding into our broader understanding of where there are overlaps and need for harmonization across quality programs. Next slide, please. And then here is a little bit in more detail about where we started our analysis and where we plan to go. As I mentioned, we did start as a baseline of looking at USCDI and seeing where there's commonalities or submissions for USCDI that apply to the quality space. We also reviewed the electronic clinical quality measures, ECQMs, currently used in CMS's inpatient and eligible clinician quality reporting programs, and data elements included in draft and published HL7 FHIR implementation guides for different use cases, such as long-term and post-acute care, oncology, and federally qualified health center reporting requirements, particularly the health center reporting requirements as that tie into HRSA I mentioned before. We also have had a series of discussions with other organizations, as I mentioned as well, to really try to identify additional data elements that would fit into this sort of quality data element list, really to identify high priority data elements. Then we also looked at areas such as the data element library and the ARC common formats. And we're continuing to explore additional areas to look, including with comments from our partners that we received as a part of the first kind of public comment into the USCDI Plus quality data element list earlier this year. Next slide, please. So just to give a quick snapshot of what is included in the USCDI Plus quality data element list. We published our version sort of 0.1 for public comment in May this year on the ECQI Resource Center. And it includes 162 different data elements, but a lot of those data elements really overlap with USCDI. We're also doing the overlap in other domain areas, as I mentioned earlier, to see kind of where there's alignment and harmonization that needs to take place. But there are also unique data elements included in the USCDI Plus quality data element list, including a few that I've listed here around advanced directives, adverse events, and functional ability and goals. Next slide, please. So the USCDI Plus Quality Initiative is intended to support the CMS's digital quality measurement strategy as their quality reporting initiatives move to a FHIR-based model. The ONC certification program currently certifies health IT for quality reporting capabilities under the CMS quality payment and hospital inpatient quality reporting programs for the recording and export, importing and calculating, reporting and filtering of clinical quality measures through conformance to the quality reporting document architecture or QRDA standard. And ONC and CMS are currently collaborating to develop the architecture for a FHIR-based quality reporting model, which will include potential development of FHIR profiles and implementations guides that the ONC certification program will measure conformance to, a new FHIR regulatory framework and certification model, development of FHIR testing tools and other resources to support this new quality reporting framework, and this new FHIR-based model. We are exploring alternative methods for measure calculation and reporting. Next slide, please. So just to say a little bit about possible policy impact the USCDI Plus quality data element list is a policy construct that's really serves as a starting point for establishing a data model to support the exchange and use of data for quality measurement across programs, payers, and care settings. Beyond our collaboration with CMS to support their DQM strategy, we are also working to sort of discover and determine how USDA Plus quality can be applied more broadly across programs at HHS. This slide includes programs who have some programs who have committed to moving along with the USDI Plus quality model, and some that we're still in conversations with about how to incorporate and make it most useful, including on sort of some of the SAMHSA and ARC aspects of it as well. And as we mature the USDI Plus initiative, we will provide additional details on how new versions are developed and timelines for comments. As you know, this is intended to be a transparent process and allow for additional and ample public input and comment into the process. And so I think there will be more information to share once we have our next iteration of our USDI Plus quality data element list available. Next slide, please. So just to close that out with a few resources that we've talked about today. Next slide. There is the USCDI web page, so that speaks to the work Al mentioned, and you can explore all of the current final versions of USCDI from version 1 through version 4 on that page. You can also look at all sort of explore level 1, level 2, level 0 data elements that aren't currently on a final version of USCDI, and see kind of where we had our starting point of all of the different data elements that have already been submitted into USCDI. Next slide, please. There's also the USCDI Plus webpage for you to explore. This webpage will be updated as we roll out additional domains and have additional information to share about additional domains. And then all of the links to any kind of comments will be included on this page in the future as well. Next slide, please. And then we're also building out a USCDI Plus platform. For those who are familiar with USCDI, this is like our version of on-deck submissions. And the USCDI Plus platform will house all of the domains that we're actively working on. So right now in this screenshot, you can see quality, maternal health, cancer, and public health. I think behavioral health is going to be added soon as well. This hasn't been officially launched yet, so stay tuned for more information about the official launch. And then next slide. Just to show you, we're also looking at the relationships across different domains. So we are, we have different data elements, and they can be tied both to different data classes and different domains within USCDI Plus. But the idea being that we're all tying back to that same data element in an effort to capture more standardization. Next slide, please. And we'll just give a little plug for those who are interested. The ONC annual meeting is taking place December 14th to 15th in person in Washington, DC. If you're interested in joining us, please visit the URL here, www.oncannualmeeting.com. We'd love to see you. We'd love to have you there. And that's it. Next slide. Thank you all. I think we're going to questions, but I'll hand it over to Haley for anything.
Yeah, just want to say thank you so much to Lisa and Al. That was really informative, and I see it's great. We're getting lots of questions coming through, so we can dive into our Q&A session. So if the attendees haven't already, feel free to use the chat to pop in any questions that you have, and we'll try to cover as many as we can. So I see we have a handful answered. So We'll go back to those if we have time to read them out loud, but I see we'll start with a few flagged for our panelists. So Lisa flagged any consideration for a UCSDI plus pediatric focus. So Lisa, what are your thoughts on that one?
So I wouldn't say that it's not being considered. So for maternal health, I think one of our initial conversations was maternal and child health. So more of an MCH lens. What we found is that conversation was getting quite large. And I think right now for maternal health, at least, we are going to have some infant kind of data elements. So thinking through if there's an impact on the mother's health, if there are particular data elements to consider and include, we are going to be doing that. I think trying to expand that out eventually is definitely a goal. But then it also gets into the question of what are we defining for pediatric, and are we defining it as less than 18 years, or is it within like a certain time period? So all that is to say that it's something that we have talked about and considered, but right now we're focusing on sort of the maternal health piece.
Wonderful. Thank you so much for that answer. Next question here. What is the difference between USCDI and USCDI plus quality?
Al, do you want to? I'm happy to address some of that, but if you wanted to kick off with like USCDI.
Just real quickly, we pretty much what we've been talking about for the last 30 minutes. USCDI is a base. USCDI plus and USCDI plus quality in particular is the delta between data that's required for everybody and data that might be necessary for to participate if the scope to participate in, amongst other things, the CMS quality reporting programs. So that the USCDI plus quality is the delta between USCDI and what those programs might require or want. Is that fair, Lisa? Did I do a decent enough job at that?
Right. I mean, USCDI is the base. It's our starting point, and quality is more an extension of it. So USCDI, particularly final versions, aren't always going to have all of the data elements you might need for a quality reporting program. So we're trying to think through what exactly those needs are, building on the foundation of USCDI.
Great. All right. Thank you so much. We have some more questions here. So one suggestion for additional data elements for USCDI plus are those that are related. Oops, sorry, my screen is jumping around here. Related to CMS ESRD QIP program. So is there material on how providers can assist with establishing a new domain similar to cancer, but instead for ESRD that CMS manages?
So ESRD has come up in conversations with us related to quality. I think, we're open to conversations around what might be useful and important for USCDI plus. I will say a key component of USCDI plus, and maybe this is just a common knowledge generally, is that ONC is a pretty small agency compared to CMS or even HRSA or CDC. We have a tiny budget. And so a key part of USCDI Plus is that we have partnerships and collaborations with other HHS agencies in particular who can help provide resources, whether that's both people resources and funding resources to help work through this. That's not to say that those resources are only dedicated to that particular agency. The idea is being that it's holistic, but that there is, some backing there from those agencies. And so I think some of those conversations help drive where we're focused, but we're open to having additional conversations. And like I said, we have had some conversations with CMS colleagues on the ESRD program. And I think there is potentially opportunities there around data mapping and what exactly is needed for the ESRD reporting.
Wonderful. Thank you so much. More questions coming through. So since USCDI Plus won't have an implementation guide, are there plans to close the loop and have new USCDI Plus submitted to USCDI and included in the implementation guide?
So I think this question is getting at that USCDI and US Core IG are closely linked, though I would not say that they're the same. Al, you're going to have to probably speak more to that. But what they're trying to get at is if there's no USCDI Plus specific IG similar to US Core IG for USCDI, what does that sort of mean? There's a few different or a couple of different pathways in my mind, because of course we're all still looking for, at the end of the day, how to implement, and implementation guides are a key part of that. For USCDI Plus, it is possible. I mean, like I said, a lot of the times we looked at data elements submitted into USCDI, some of them might be on a final version, some of them might not be. Like they might be at level 2, sitting at level 2 ready to go, and maybe as USCDI slowly expands incrementally over time, that data element that might be on a quality data element list right now does get added into a USCDI final version. And if that's the case, then that would ultimately end up in some version of a US Core. Again, I don't think we can say USCDI and US Core are one-to-one, but they are closely tied. Now for USCDI Plus, we are also looking at existing IGs. So there might be data elements on a final USCDI Plus data element list that reference different IGs. But there might be some, like for quality, USCDI Plus quality, that also have a number of data elements that are closely tied to like QI Core IG. And that's some of the focus and work that we're doing with CMS and some of their digital quality measure and move to FHIR-based quality reporting. So I think, there's like a couple of different pathways at least that I can think of. And I don't know, Al, if you want to speak any more to like the ties to USCDI and US Core IG, which I think is what the person is getting at here.
Yeah, and it sounds like it's related. I don't know if it's the same person asking, but it seems like it's related to a question that I just answered about what are the chances that a USCDI Plus data element can make it into USCDI someday. And so a couple of things. The answer to that question was, if you haven't read it yet, is things that are maybe submitted for USCDI but not included in USCDI, maybe not included because it lacks some maturity in standards, or it lacks a certain breadth of applicability to multiple use cases. It might make perfect sense to be in USCDI Plus, one of the USCDI Plus programs, but it doesn't meet the criteria for maturity and breadth of applicability to be considered for USCDI itself. Should that change, standards mature, the data element is kind of reshaped or is able to be expressed across multiple different use cases, we certainly would consider it for USCDI. Just because, so USCDI, a lot of the new data elements in USCDI don't already have a place in the US Core IG. That's what happens once we publish a final version. US Core goes to work. The structured docs working group works on the CCDA updates, in order to accommodate these new data elements in USCDI. So should something be, we want to, one of the criteria that we have for consideration for USCDI is it reasonable to think that we can work this into a US Core or CCDA implementation guide? We kind of estimate that ahead of time. We work with HL7 to refine that estimate. And if it seems like a reasonable thing and it meets a number of different use cases, it helps with a number of different use cases, when we consider it for the next version, then it'll eventually get worked into an IG. We'll figure out a way we work with HL7 to get it into an IG. So that same thing could happen with USCDI plus data elements that mature and reshape in order to be added to USCDI.
Right. All right. Next question we have here is ONC also collaborating with CDC in standardizing quality data elements through its USCDI Plus quality program?
I think that the simple answer is yes. ONC has had collaborations between CMS and CDC for a number of years, particularly with the National Hospital Safety Network. I think that's what it is, NHSN at CDC. And so we've worked with colleagues there at CDC. We've also been working with some of their colleagues that are a part of their broader data reporting and policy work at CDC as well. And that's some of the harmonization effort that we've done between quality and public health work of the USCDI Plus domains.
Wonderful, thank you. All right, another question here. Can you provide a few use cases for the USCDI Plus platform?
So for the USCDI Plus initiative, generally, we have domains as like the broader, this comes down to nomenclature to a certain extent, but that's like the broader program area description. So as I mentioned, that would be like quality, public health, cancer, maternal health, and behavioral health. And then for each of those domains, some of them have specific use cases that we're working on. Ones that particularly stick out in my mind for like public health is around like case surveillance as a use case. For quality, we haven't been as specific in defining use cases right now, but I will say, like, I guess one kind of use case is some of the work we've done with CMS on their ECQM reporting efforts, and then the HRSA work as well on their uniform data system efforts to kind of harmonize everything there. I think as we kind of roll everything out in the platform, everyone will be able to see kind of the final use cases, but some of those are still in kind of discussion as well.
Great. All right. Thank you. And just a reminder that there are lots of written responses provided in the Q&A section. So if we're not, speaking to them out loud, our presenters have been answering those as we go as well. So please take a look at that and make sure you see those responses here. And we'll do a few more questions here before we wrap up. All right. So next question here is, who is held to these requirements or standards? If not the EHR, it has limited impact.
Yeah, Al, do you want to go?
Yeah, sure.
Right.
So, I'm sorry, can you point me to the question? I want to make sure I'm reading the question right.
It's anonymous attendee 2:44 p.m.
And I can read it once more, add it in the chat. But
I got it.
Okay.
No, I got it. Thank you. So the ONC certification criteria applies to health IT products that certify to the ONC certification program. The certification program is a voluntary program, although it's required for a lot of CMS programs to participate in their programs using certified technology. So it's one of those, you don't have to, but if you want to do business with CMS sort of thing. So EHRs are required. So EHRs can certify to the ONC certification program using their products. But there are EHRs out there that have not certified, but those EHRs can't be used to. Well, perhaps they can be used, but I defer to CMS on this. Like, I'm not sure if I'm saying this right, but you can voluntarily certify it to our ONC certification program through an EHR. That's who it applies to. There are requirements in order to certify. And you have to continue to demonstrate the ability to do the things that you did to certify. But it's voluntary to certify a product to our program.
Great, thank you. Thank you both. We'll see if we can do one or two more questions here. So can you speak a bit about the rationale for USCDI elements also being included in the USCDI Plus data sets rather than the Plus sets being only additional elements? And then the follow-up question, is there concern about the ability to keep the element requirements in sync as the USCDI Plus versions expand over time?
Yeah, so, I mean, this speaks to a system that perhaps, we're humans and we're trying to keep up with both USCDI and USCDI Plus updates. So to the second question, yes, I think we have concerns about making sure it's updated, but it's similar to the concerns around when we update USCDI with a new version, then making sure US Core kind of catches up to it. I think the rationale for including specifically some USCDI data elements like being called out in USCDI Plus data sets is that not all domains for USCDI Plus, or let me say this, not all USCDI data elements are as maybe closely tied or important for specific domains in USCDI Plus. So I've even asked this question before at ONC, like, do we really need to do that? And I think right now our thought is that we're trying to call out specific USCDI data elements that are critical to that domain. In theory, if it's an extension of USCDI, we are already saying all of USCDI is really included because of already existing program requirements and everything else. Now, getting to that point of if it's cyclical and we're trying to always kind of make sure we're keeping up with USCDI as we're updating USCDI Plus, that sort of gets into the process of things. And, I can't say none of that will change over time as we're working through all of that.
Great. All right. Thank you. I think that was all we had time for in terms of questions and answers, but I really appreciate all the engagement. These were great questions from the group and always brings a lot of value to these discussions. Yeah, just thank you everyone for your questions and involvement in today's session. We hope you'll join us next Wednesday at the December 6th session for our making preview. And as always, please visit the CMS MMS Hub to stay up to date on all the latest MMS news, events, and quality measurement resources. Again, this recording will be posted on the MMS Hub later, but we have distributed the link to the slides for now. And yeah, we look forward to seeing you next week, and thank you for attending. Thank you so much, Lisa and Al, as well. Appreciate you both very much.